Hello friends, in the previous lecture part 2 of CAD I talked to you regarding acute coronary syndrome. Now I will be talking to you regarding complication of acute myocardial infarction. First is arrhythmias. Arrhythmias are the most common complication, and arrhythmias are seen in around 90% cases of acute MI. So first we talk about tachyarrhythmias. One of the common causes of arrhythmias is, of course, myocardial ischemia is there beyond doubt, but other things which can precipitate arrhythmias are hypo or hyperkalemia or any acid base disturbance. It is very essential that not only we have to look into the coronary cause of arrhythmias, we have to rule out electrolyte and acid base disturbance. If they are there, they have to be corrected on urgent basis. Otherwise, once we presume, then ventricle premature beats or so-called ventricle premature contraction are one of the most common arrhythmias. Okay. Ventricular tachycardia. Now regarding ventricular tachycardia, patient may have normal BP or patient may be reduced BP. If normal BP is concerned, then you treat by drug therapy. Drug commonly used are lignocaine, amiodarone. But if his BP is reduced, then you go for DC shock. Patient may have atrial fibrillation also. You treat again by antiarrhythmic drugs, or we can use even low dose DC shock, maybe 50 joules. If it is causing too much of tachycardia and hemodynamic instability, otherwise you try to manage by drugs. Second thing is bradyarrhythmias. And heart blocks. Patient may have first degree heart block, nothing worry about it. 2A block, so-called Wenke-Back phenomena. Nothing worry about it. But if patient has 2B block or complete heart block, so-called third degree, these are the need of urgent pacing. Similarly, patient may have bradycardia, heart rate less than 60. If patient is asymptomatic and hemodynamically stable, nothing worry about it. But if patient is symptomatic or hemodynamically not stable, then you can use injection atropine or injection isoprenaline. but still the patient's heart rate not being improved, then we can think of the pacing also. What else patient can have? Patient can have left bundle branch block, right bundle branch block, bi or tri fascicular blocks. These are also the indication of pacing. You need to have temporary pacemaker for this thing. Okay. Now the next complication is heart failure. This is the most dangerous complication because maximum mortality occurs due to heart failure. Heart failure also induces tachycardia or arrhythmias, that is again add on to the mortality. So in another way around, pump failure is the single most important prognostic factor also. So pump failure is the single most important prognostic factor. And what criteria we use? We use Phillips classification. Phillips criteria or so called Phillips classification to know the prognosis of a case of MI. We have class 1 in a MI patient. There is no evidence of left heart failure. Then the mortality is around 20%. We have class 2. There is evidence of heart failure in the form of third sound, basal crepitations. Heart failure evidence are there. Mortality is about 20 to 30%. Class 3. Patient has pulmonary edema, but his systolic BP is above 90. Mortality is somewhere around 50 to 60%. Class 4. Patient is in cardiogenic shock. That is, he has systolic BP below 90. Then mortality may be as high as 79 to 90%. These mortality figures are in general. The figure may vary from center to center, but by and large, idea is to know that pump failure is the single most important poor prognostic factor, and patient in cardiogenic shock has very high degree of mortality, and these are the patients who should be managed by intra-aortic balloon pump, or we have to manage, and plus we have to give drug like dopamine or dobutamine. Okay. The fourth complication is pericarditis. Patient again has pain chest, but the pain get relieved on bending forward, and of course the main thing is pericardial rub. Pericardial rub is there. These complications, arrhythmias, pump failure, pericarditis, they can occur within first 48 hours of MI. Now there are some complications which occur from 3rd day to 14 days. This include deep vein thrombosis. It has to be taken care, otherwise it can cause pulmonary embolism. That's why all patients initially we always prefer to give heparin. Then we talk about embolism, because clot may form in LA, especially if patient has atrial fibrillation. So it can lead to systemic embolism can occur from MI. Right ventricle infarction is one entity which the patient even can come by like this only in the presentation, is a special thing. In this JVP is raised but lungs are clear. BP may be normal or may be reduced. In this we always go for Swan, Gans, catheterization, because in this the mainstay of treatment is fluid therapy. Fluid therapy is the main treatment. Point to be noted, despite raised JP, we always give IV fluid to raise the blood pressure if BP is low. And in this patient, in RV, in fact, nitrates are usually avoided. The reason being nitrate can further lower down the blood pressure. Then we talk about more complications. We talk about papillary muscle dysfunction. This may occur even within 48 hours, but at time it may come after 48 hours. This is the one thing which lead to late systolic murmur, and in this case patient can have acute pulmonary edema. It can cause acute pulmonary edema. Then we have rupture of interventricular septum. This is the heart. Rupture may occur in the interventricular septum. So what we get? We start getting, it's a type of VSD. Patient develop ventricular septal defect. So the large amount of blood will come from LV to RV, and this blood will enter the pulmonary vein and can precipitate acute pulmonary edema. Then we have rupture of free wall. Free wall rupture. What is this? This is the myocardium. This is the pericardium, and rupture occur here. That means it lead to sudden onset of cardiac tamponade. The whole blood will accumulate in the pericardial cavity. As the heart myocardial wall is ruptured, and this is the aorta, the myocardium will not be able to pump the blood forward. So mechanically there will not be any pumping of the heart because pump is not leaking. But if you do ECG recording, you will get electrical activity. So we are getting electrical activity on ECG but no mechanical activity, and this is known as electromechanical dissociation. This is known as electromechanical mechanical dissociation. In this, the BP electromechanical dissociation. In this, the BP is almost 0, and this patient need to have urgent cardiac surgery for repair, otherwise patient will die. It's emergency. Then the next complication is Dressler syndrome. This is usually the late complication. Patient has pain chest, pyrexia. Patient has pleurisy or pericarditis. So you may get pleural rub, pericardial rub. This is usually due to autoimmune. So treatment is NSAID, and sometimes we can give corticosteroid also. Then we have LV aneurysm. It's again a late complication. What happened? This is the myocardium, and a part of the myocardial where the plug, where the infarct occurred, but fibrous tissue was weak, so it bulges out. This we can, and what we get in ECG, in this the ST elevation remain persistently high. Normally ST segment elevation, it comes down to normal in few days, but here it persistently raise high. So if patient come to us after 2, 3, 4 months of follow up and you are still finding ST elevation, you suspect about LV aneurysm. This you can diagnose by echocardiography, and the main concern is it is a source of clot formation, which can cause embolism, so it again need to be corrected surgically. Then we talk about shoulder hand syndrome. Shoulder hand syndrome. Patient has complaint of pain in the shoulder joints. It's again a late complication, and patient has complaint of erectile dysfunction. The most common cause in post MI case of erectile dysfunction is anxiety. Or second thing which contribute to this is beta blockers. Then if not, either of these things are not there or not being controlled, then we can give this patient sildenafil. But point to be noted, if you plan to start therapy with sildenafil in these patients, nitrate should not be used, because if you use these two drugs together, nitrate and sildenafil, it can lead to drastic fall in blood pressure, which could be very, very dangerous. So these are the complication of acute myocardial infarction, and of course sudden cardiac death is a very big problem, and about 40 to 50% they die in first 24 hours of acute MI. So sudden cardiac death can occur in this patient. Thank you very much.